Hello and welcome. This is Rachel Moses and Shatoya Gilbert will be presenting on adverse childhood events and trauma in the child and adolescent. By the end of this presentation, participants will be able to identify common types of adverse childhood experiences that have potential to be traumatic, explain how ACEs and trauma can affect mental and physical health in the child and adolescent. We're also going to discuss the importance of ACE screening, and we're going to identify preventative and protective interventional strategies aimed at reducing the effects of ACEs in the child and adolescent. We have chosen constructivism learning theory for this presentation. This particular theory proposes that learners actively construct new knowledge by integrating new information with their prior experiences and existing clinical understanding. Learning occurs when students synthesize new concepts with what they already know. Our target audience are graduate-level psychiatric mental health nurse practitioner students. These students have prior nursing knowledge and clinical experience. The presentation builds on foundational knowledge of child development, psychopathology, and neurobiology. Learners are encouraged to connect ACEs research with clinical screening, trauma-informed care, and intervention strategies. A pre- and post-test will be provided to promote reflection and knowledge integration. Our pre-test questions. Which of the following best describes an adverse childhood event? A. Traumatic events occurring before the age of 18 that may affect physical, mental, and behavioral health. B. Isolated events occurring during childhood that resolve without long-term impact. 3. Psychiatric disorders diagnosed exclusively during childhood. Or D. Genetic vulnerabilities that increase the likelihood of psychiatric illness in adulthood. Number 2. Which statement best explains how ACEs and trauma can affect both mental and physical health in children and adolescents? A. ACEs primarily affect mental and emotional development, rarely having an impact on physical health. B. Children exposed to ACEs develop physical illness only if a genetic predisposition is present. C. Trauma exposure can dysregulate the stress response systems, increasing the risk of psychiatric symptoms and chronic physical health conditions. Or D. The effects of ACEs are limited to childhood and typically resolve by adolescence. Question number 3. Why should providers screen for ACEs? A. Addressing ACEs in the pediatric population may improve overall health and well-being. B. Child development can be negatively affected both short-term and long-term. Early detection creates an opportunity to prevent additional ACEs and trauma. Or D. All of the above. Number 4. Which of the following best represents both a protective factor and an effective intervention for reducing the impact of ACEs in children and adolescents? A. Limiting discussion of traumatic experiences to avoid re-traumatization. B. Pharmacologic treatment as a first-line management for trauma-related symptoms. C. Access to a stable, supportive caregiver combined with trauma-focused psychotherapy. Or D. Delaying intervention until adolescence when children can better verbalize trauma. So what is all this talk about, an adverse childhood event? What is it? ACEs are events that occur in childhood before the age of 18. These events are generally preventable and have the potential to be traumatic. And what is trauma? Trauma occurs as a result of the inability to cope with events or situations that have happened. It may be a single isolated event or due to the ongoing exposure. Traumatic experiences do not affect everyone in the same way. Adverse childhood experiences disrupts a child's sense of safety, stability, and attachment. Common examples are physical, sexual, and emotional abuse, physical or emotional neglect, violence against the child's mother, household members who were substance abusers, had a mental illness, or who were suicidal, incarceration, loss of a parent due to separation or divorce, As previously mentioned, ACEs can occur as a single event or ongoing exposure. Ongoing exposure to conditions and situations such as ACEs can lead to trauma. The ACE study shifted the way we think about trauma. It was a large research study done in the 1990s. Researchers wanted to understand whether difficult childhood experiences like abuse, neglect, or any of the common ACEs listed on the previous slide, if they had any long-term impact on a person's health. They surveyed over 17,000 adults and found a very clear pattern. The more adverse experiences someone had before the age 18, the higher their risk for mental health disorders, substance use, and chronic medical conditions, and even early mortality. This study clearly shows that early adversity has lifelong biological and health consequences. The ACE pyramid was developed by the CDC. It's a visual model that shows how adverse childhood experiences can cascade across the lifespan. It starts with childhood trauma at the base, which can disrupt brain development and stress regulation. That disruption can lead to social, emotional, and cognitive difficulties. This increases the likelihood of health risky behaviors. Over time, those behaviors and biological stress responses contribute to chronic disease, disability, and social problems, and even early death. The model helps us understand that ACEs are not isolated childhood events, but they are foundational drivers of lifelong health outcomes. This slide highlights how ACEs impact not just individuals, but entire populations. Research shows that ACE-related conditions such as anxiety, depression, asthma, and arthritis result in enormous healthcare and societal costs, reaching trillions of dollars annually. There's also a clear correlation. The more ACEs experienced, the greater the risk of poor health outcomes. Importantly, ACEs are not distributed equally. Certain populations, including minority ethnic groups and the LGBTQ plus individuals, experience higher exposure due to systemic and social inequities. This reinforces that ACEs are both a clinical issue and a public health concern. Traumatic events look different for everyone. What may affect one child may not affect another the same way. It may not affect them at all. Everyone does not express their feelings over an experience like another person may. Factors that make a person more likely to experience trauma may include a history of prior trauma. Someone who's already experienced a traumatic experience, they may feel more traumatized if exposed to another traumatic experience. A current or history of mental illness may get worse after a traumatic experience. How close someone is to the experience. Was the event witnessed, or was it just heard about? The lack of mental health support. Many emotions may be felt after a traumatic experience, and without mental health support, such emotions may be harder to handle. Dissociation. Some people try to disconnect themselves from what is going on around them, trying not to face the reality of the event, what has happened. The lack of a support system. Without the protection of a support system, someone may endure long-term events from a traumatic event. So why do we screen for ACEs? As we've learned in previous slides, adverse experiences can lead to a cascade of negative outcomes. Screening increases awareness of ACEs. When we're able to identify ACEs early, it allows us to intervene before symptoms worsen, or maybe we can prevent any additional ACEs or any trauma from occurring. We can implement treatment modalities such as trauma-informed care. Screening also helps us to strengthen protective factors, connect families with resources that they need. Ultimately, screening can help to improve long-term healthcare outcomes. On this slide, we're going to discuss the neurobiology and how trauma and ACEs affect the brain. A normal neurobiological response to a stressful or threatening situation activates the HPA axis. Ultimately, this leads to the release of cortisol, which puts the body into an alert state. Normally, once the stress or a threat has passed, cortisol levels return to baseline. The body returns to its normal state of homeostasis. In a chronic or toxic stress, the body remains in a high alert state. So, why is this an issue for children? Toxic stress can inhibit the brain's capacity to grow and develop properly and may lead to structural changes. Affected regions typically include the amygdala, the hippocampus, and the prefrontal cortex, resulting in difficulties with emotional control, learning, impulse regulation, and attachment. The persistent elevation of stress hormones causes continuous damage to the body, leading to chronic health issues when they're an adult. This may also lead to other neurological deficits. ACEs significantly impact both mental and physical health. Chronic exposure to stress, as we previously mentioned, disrupts normal neurodevelopment. Over time, toxic stress, it increases vulnerability to psychiatric conditions such as PTSD, depression, anxiety, substance use disorders, sleep disturbances, eating disorders. Physically, the same stress mechanisms contribute to long-term inflammation, increases the risk of heart disease, obesity, chronic lung disease, and stroke. So ACEs, they're not just emotional experiences. They can also influence long-term health outcomes. As we've mentioned several times over the last several slides, childhood trauma, it's different for everyone. The way that one child behaves may not be the same for others, but it is important for us to recognize that clinical presentation, it may vary significantly by the child's developmental stage. This podcast here is a YouTube video from Children's Health of Orange County. They do a very good job at explaining what you would potentially see based on the child's developmental stage. It breaks it down by infants and toddlers, the school-age children, and adolescents. I'm going to hit on just a couple of those. So for our infants and toddlers, what we may typically see are behavioral regression, like bedwetting, thumb-sucking, fear of separation from their parents or their caregiver, extreme crying, throwing a temper tantrum, attachment issues, difficulties forming trust or emotional regulation with their caregiver. For school-age children, we typically see anxiety, sadness, some social withdrawal, maybe aggression, difficulty concentrating, not wanting to go to school, nightmares, somatic complaints such as unexplained headaches, stomach aches, chronic pain. Adolescents, that's when we typically start to see the substance use, self-harming behaviors, eating disorders, risky sexual behavior. They have a lot of depression, intense loneliness, a feeling that the world is unpredictable, it's unfair. Social withdrawal, they tend to be rebellious, difficulty with self-concept. There's the PowerPoint also, or the presentation, also points out some key indicators for all ages, and they typically all have problems with sleep disturbances, a fearfulness of some sort, and those somatic complaints such as the unexplained headaches, stomach aches, and chronic pain. As psychiatric mental health nurse practitioners, our role includes early identification of ACEs. We want to be sure to coordinate care and ensure access to supportive services to promote recovery and resilience for our patients. Trauma-informed care focuses on recognizing the impact of trauma, responding with empathy, and we want to avoid any re-traumatization. Evidence-based interventions such as trauma-focused cognitive behavioral therapy, family therapy, and EMDR help children process traumatic experiences and help them to develop healthier coping mechanisms. It's essential to address any contributing factors such as parental substance use or domestic violence through appropriate referrals. For other children, it may be beneficial for after-school programs, mentoring programs, tutoring, any additional support to help them maintain resilience and avoid any further trauma. This slide discusses preventative and protective strategies for reducing the effects of trauma and ACEs. Some preventative things that we can do as clinicians is to recognize our role in preventing ACEs. Prevention of ACEs and trauma begins with becoming educated on simply what they are, how to recognize them, how to prevent them, and how to care for those patients that have experienced them. We should also incorporate screenings into our practice. Protective factors or strategies. Providers should educate children and caregivers on protective factors which can potentially decrease the chances of experiencing ACEs or trauma. Individual and family protective factors include caregivers have steady employment and income can provide necessities for children. Families provide safe, stable, and nurturing relationships in home environment. Caregivers, adults, know how to resolve conflicts peacefully and teach children to problem solve peacefully. Some community protective factors include providing safe, stable housing access, where residents feel connected and are involved in the community. Medical and mental health services are easily accessible. This slide discusses evaluation of treatment outcomes. How do we know that our efforts are being successful with the child? Treatment outcomes in children with ACEs are evaluated across multiple domains, not just their symptom reduction. We look for improvements in their emotional regulation, their behavior, their school and social functioning, as well as their caregiver understanding and family dynamics. Long-term outcomes, we want to include improved resilience, reduced risk of behaviors, and decrease the likelihood of chronic mental and physical health conditions. Now we'll begin our post-test. Question number 1. Which of the following best describes adverse childhood events? Option A is the best selection. Traumatic events occurring before the age of 18 that may affect physical, mental, and behavioral health. Question number 2. Which statement best explains how ACEs and trauma can affect both mental and physical health in children and adolescents? Option C. Trauma exposure can dysregulate stress response systems, increasing the risk of psychiatric symptoms and chronic physical health conditions. Question number 3. Why should providers screen for ACEs? The correct option is option D. Screening for ACEs, addressing ACEs in the pediatric population may improve overall health and well-being. Child development can be negatively affected by ACEs, both short-term and long-term. Early detection creates an opportunity to prevent any additional ACEs and trauma. All are correct. Question number 4. Which of the following best represents a protective factor and an effective intervention for reducing the impact of adverse childhood experiences in children and adolescents? Option C. Access to a stable, supportive caregiver, also combined with trauma-focused psychotherapy. This concludes our PowerPoint presentation of adverse childhood experiences and trauma in the child and adolescent. We hope you have found the information valuable, and we appreciate your attention.